Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you for joining us today and our friends at Mariposa Community Health Center for hosting today's session, Clot-ology 101, Oral Anticoagulants in AF and DVT PE with Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consulting. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, it's all yours.
Thank you very much, Jennifer, and good morning, everybody. Welcome to today's MAVEN Project presentation on oral anticoagulants. Per the CME guidelines, nobody that has anything to do with this talk have any relevant financial relationships. And the activity is designated for 1 hour of Category 1 credit for physicians. So the learning objectives are that I hope at the end of this talk, you'll understand the pharmacology and pharmacokinetics of oral anticoagulants. You'll recognize indications and contraindications, particularly in atrial fibrillation and peripheral and DVT and pulmonary emboli. Know the doses and duration of therapy, how to switch, and to recognize the difference in treatment of VTE in cancer patients. So to start off, this is the coagulation cascade that we learned about in medical school. There are 2 pathways, an intrinsic pathway and an extrinsic pathway shown here with various factors, eventually leading to factor 10A. 10A in the presence of 5A becomes 2A, which changes fibrinogen to fibrin and subsequently to a cross-linked clot. VKA, or warfarin, acts at many of the points on this cascade. The direct oral anticoagulants act on factor 10A, except for dabigatran, which is a direct thrombin inhibitor. So the pharmacokinetics of the oral anticoagulants that we use, starting with warfarin. Warfarin is a competitive antagonist of vitamin K in the liver. So the more vitamin K you ingest, the less effective warfarin will be, and in order to maintain the therapeutic level, you'll need a higher dose. The half-life of warfarin is days. It requires frequent blood tests. There are frequent food and drug interactions, and there are dietary restrictions because of the competitive antagonism. On the other hand, the direct oral anticoagulants either are a direct thrombin inhibitors, such as dabigatran, or factor 10A inhibitors, the rest of them. The half-life is, of course, much shorter, somewhere between 5 and 17 hours. No testing is needed. There are no food or drug interactions, and there are no dietary restrictions. So here we have an 81-year-old woman who came to the clinic one day complaining of a cough. Her daughter requested an antibiotic. An alert medical assistant noticed that her pulse was rapid and irregular. and so did an EKG even before I saw her. The EKG shows atrial fibrillation. It's a rapid, irregular supraventricular rhythm with no visible P waves. So this is AFib or AF. The cough turned out to be due to heart failure, not pneumonia, and she did not need an antibiotic. She needed furosemide. Atrial fibrillation. This is one of my favorite slides. It depicts the difference between sinus rhythm with coordinated contraction of atria and ventricles, as opposed to atrial fibrillation, where there are 360 plus impulses that bombard the AV node with variable penetration. And so the rhythm is irregular because of variable refractoriness. So you get an irregular rhythm in the ventricle. This talk is not designed to review the entire treatment for atrial fibrillation, but this comes from the European guidelines just published the end of August 2024. And this care plan involves comorbidity and risk factor management, such things as obesity, diabetes, hypertension, sleep apnea. Treating those conditions also treats the atrial fibrillation. A for avoid stroke and thromboembolism. That's what we're talking about today. R for reduce symptoms by rate and rhythm control. And then E for evaluation and dynamic reassessment, meaning don't, once you treat the patient, don't forget about it. Follow up, repeat cardiograms, find out if patients are taking their medicines, and so forth. So stroke prevention in atrial fibrillation can be either pharmacologic or non-pharmacologic. Pharmacologic treatment reduces the risk of thromboembolism by 2/3. So it is remarkably effective. Consists of either warfarin or the direct oral anticoagulants that we have already mentioned. Aspirin or clopidogrel are not effective. They've been specifically tested for this condition. They are not effective and carry the same bleeding risk as the others. So do not use aspirin or clopidogrel or the combination for treating atrial fibrillation. Non-pharmacologic measures include left atrial appendectomy at the time of cardiac surgery for some other condition like aortic stenosis or coronary bypass, and the left atrial appendage closure device, the so-called Watchman device. Atrial fibrillation is undertreated. Undertreated in the sense that anticoagulation is indicated for many people. We'll talk about that in a little bit. But on a worldwide average of patients who do not have rheumatic heart disease and have a CHADS score greater than 2, it's only 44%. It's better than that in North America at 65%, but that still leaves a number of people untreated. And so the conclusion of this particular study is that oral anticoagulants are underused. So, one of the ways of determining whether and when to treat treat patients with atrial fibrillation in order to prevent thromboembolism is this score called the CHADS-VASc score. You get points for congestive heart failure, hypertension, your age, 1 point if you're between 65 and 74, 2 points if you're over 75, diabetes, stroke, TIA, or thromboembolism gets you 2 points, other vascular disease gets you a point, and women get 1 point. And as you can see here, with a CHADS-VASc of at least 2, anticoagulation is indicated. There are some other additional risk factors that increase the risk of stroke, which are not included in that, including a higher atrial fibrillation burden, obesity, hypertrophic cardiomyopathies, an infiltrative cardiomyopathy called amyloid cardiomyopathy, poorly controlled hypertension. The CHADS-VASc score includes hypertension regardless of what the blood pressure happens to be at the moment, but poorly controlled hypertension is an additional risk factor. Kidney dysfunction with proteinuria and a large left atrium. To balance the benefit that in reducing thromboembolism, we have to consider the bleeding risks, especially as presented with patients already on antiplatelet therapies, patients who take concomitant nonsteroidal anti-inflammatory agents, and this is sort of a bugaboo because people take ibuprofen or naproxen and don't tell you about it. So you have to specifically inquire and have people not do that. Liver or kidney dysfunction, alcohol use, age, nothing we can do about that. We hope that we all get older. Prior intracerebral hemorrhage, prior GI bleeding. And okay, there are bleeding risk scores. The Has-Bled score, which was based on derived during the days of warfarin-only treatment, and a subsequent score called the DOAC score based on direct oral anticoagulants in the more modern era. But the European guidelines, which just came out, recommend against using risk scores. They just recommend that you mitigate bleeding. So here we have an 86-year-old woman who presented with paroxysmal atrial fibrillation. She had a history of controlled hypertension, osteoporosis, and mild cognitive impairment. She lives in an assisted living facility and presented with episodes of palpitations, heart fluttering, was found to have paroxysmal AFib. She's fallen a number of times. Her kidney function is reduced, but not greatly so. Her CHADS-VASc score is high, 4. Her bleeding scores, which we calculated when we made this slide, give her a moderate risk. And so the question is, should we anticoagulate her or not? Particularly since she's fallen several times. That's a yes or no question. Put some answers in the chat. Should we anticoagulate her? Yes or no? Okay, so one says no. Anybody else weigh in on this? Two other people say yes. Okay, well, we have a mixed result. And the answer is yes. Elderly patients are at increased risk for both stroke and for bleeding, but the benefit outweighs the risk of bleeding. And certainly fall risk should not generally be considered to be a contraindication. I'll be more specific about that in the next slide. But somebody did a study where they estimated that it would take 295 falls to outweigh the benefit of oral anticoagulation. So the risk of falls is rarely a contraindication. On the other hand, you have to discuss with the patient and the family using a shared decision-making approach. So this is the indication for the antithrombotic therapy and atrial fibrillation from the 2023 American College of Cardiology, American Heart Association guidelines. Okay, so calculating the risk on a yearly basis is a class 1 indication. The classification of classes is class 1 is recommended. Class 2A is, this is a strong recommendation. This is 2A is a moderate recommendation. 2B is a considerate type of recommendation. And class 3 is either no benefit or harm. So if there's if the patient exceeds the risk threshold for anticoagulation, that is, it's recommended for if the risk is greater than 2% per year, which is a CHA2DS2-VASc score of 2. If the CHA2DS2-VASc score is 1, you can either decide to or not to anticoagulate. If the CHA2DS2-VASc score is 0, most people will not anticoagulate that patient. The direct oral anticoagulants are preferred over warfarin because they result in less bleeding, except for mitral stenosis and mechanical heart valves. And again, aspirin or clopidogrel are not recommended because they're not effective. Long-term anticoagulation is contraindicated where there's severe bleeding due to a non-reversible cause, either systemic or intracranial, intraspinal. If there's serious bleeding related to recurrent falls, that would be a contraindication. But long-term anticoagulation is still reasonable if there's bleeding that involves the GI tract, the pulmonary or GU systems that's treatable, you see, or isolated trauma or related to procedural complications. So this is a consult, an e-consult that I got from the MAVEN Project. A 54-year-old asymptomatic man with hypertension. His CHA2DS2-VASc score is 1. And he has atrial fibrillation as shown here on this electrocardiogram. Should he be anticoagulated? Should we use aspirin? Well, the answer to aspirin is no. But should we or should we not use aspirin? So having raised that question, there are a number of pearls that Peter Zimmerbaum, who's the Associate Chief of Cardiology at Beth Israel Deaconess Medical Center and one of the atrial fibrillation gurus, has given us. One is that atrial fibrillation is never a one-time occurrence. It will always recur. The pattern, frequency, or amount of atrial fibrillation does not influence long-term coagulation decisions. That is, Paroxysmal atrial fibrillation should be anticoagulated as well as uh, permanent atrial fibrillation. Atrial fibrillation, ablation or the use of antiarrhythmic drugs does not allow discontinuation of oral anticoagulants, of anticoagulants. Atrial fibrillation, atrial flutter, atrial flutter presents the same problems as atrial fibrillation, rate and rhythm control, and thromboembolism. So patients with atrial flutter should be anticoagulated. Aspirin doesn't count. We talked about that already. And so here are a number of scenarios. Should we anticoagulate with a direct oral anticoagulant or with warfarin? This is a patient that saw me in the clinic, an 88-year-old asymptomatic woman with an irregular pulse. Her ECG showed atrial fibrillation. Should we anticoagulate her? The answer is yes. And so we prescribed apixaban, one of the direct oral anticoagulants. Here's another patient of mine, a 77-year-old woman who had rheumatic heart disease, who status post-mitral valve replacement for severe mitral stenosis with permanent AFib, and she should be anticoagulated with warfarin. Here's a 50-year-old man who presented with a left hemiparesis, which was thought to be cardioembolic when he was found to have short episodes of AFib on an ambulatory monitor. So even though he's only 50, he has a cardiac source of emboli, and he should be anticoagulated. This gentleman was a problem. He had a cabbage 3 years ago, and a month later was found to have atrial fibrillation. AFib is common immediately following cardiac surgery, and it's often considered to be a one-time occurrence, and so people aren't on chronic anticoagulation, but he had AFib a month later, which indicates that he's probably at risk. So he was taking rivaroxaban, except that he had persistent hematuria, and we couldn't keep up with his hematocrit and hemoglobin. So so this is the cardiologist's nightmare, if you want to look at it that way. He was treated with the Watchman device. Here's a 43-year-old woman who in the past had a provoked pulmonary embolism with a short episode of AFib, and we did not anticoagulate her. Okay, so back to our man. Here's the Chad's Vask of 1. So you think we should anticoagulate him? Yes or no? Put your answers in the chat. I think here there's no definite, no right answer. It could be either way. Yeah. Wait a minute. Do we have? Oh, here's a question related to mitral valve replacement. The question is, regardless of whether it's a mechanical or a tissue valve, is first line always Coumadin? And the answer is no. Just with mechanical valves, for sure, it's Coumadin. The DOACs were tried with mechanical valves and found not to be effective. So with a mechanical valve, it's always Coumadin. With a tissue valve, it doesn't need to be. But this lady had severe mitral stenosis, and based on that history, we used Coumadin. Or I shouldn't use to say Coumadin. Coumadin, Coumadin is a brand name. You're not supposed to use those in CME talks, but but it's so commonly used. It's kind of like calling tissue, facial tissues Kleenex, which is a brand name. Now, turning to another problem, here is a 48-year-old woman who complained of the sudden onset of shortness of breath for 3 days. She came into the clinic on the 2nd of January, was seen by one of our nurse practitioners. She had no cough, no fever, no chest pain, no wheezing. She was a non-smoker. She had no leg pain or swelling. She works at Home Depot and does a lot of walking. Her exam was totally unremarkable. Her ECG and chest X-ray were both normal. She was given an albuterol inhaler, which didn't make any difference. And she returned 2 days later with worsened shortness of breath. What's going on here? Right? She's short of breath for no good reason, really. She doesn't have lung disease. She doesn't have an infection. Could this be pulmonary emboli? Well, it could be, because she then related the past history that she had previously had a DVT with pulmonary emboli 15 years ago when she was on oral contraceptives. And so we did a D-dimer, which was very positive. A chest CT angiogram showed extensive bilateral pulmonary emboli, and she was treated with apixaban and did very well. The diagnosis of pulmonary emboli require a high index of suspicion. The symptoms are not specific. They may be mild or absent: shortness of breath, chest pain, cough. On exam, you may see tachypnea for otherwise unexplained reason. Patient may have leg swelling or tenderness, indicating the possibility of a DVT. The patient may have a tachycardia. Lab tests are CBC, blood gases, BNP, troponin. D-dimer is the inflammatory marker we use, and if the D-dimer is low, the chances that it's PE are not high. In the case of our patient, there was no question. The most common ECG findings are sinus tachycardia and nonspecific STT changes, although there is a pattern called the S1Q3T3 pattern that was described by Doctors McGinn and Paul Dudley White back in the 1930s, which is not specific for pulmonary emboli, although in the right setting, you should consider pulmonary emboli. Chest X-ray findings are generally non-specific and may be normal, but there are two signs that I'll show you. And of course, CT angiogram is the definitive test. Okay, here's a 71-year-old man with hypertension who noticed new shortness of breath and vague discomfort near his right scapula. Saw his PCP, ordered an EKG that showed a new right bundle branch block. He was then seen by a cardiologist for an urgent appointment and was scheduled for a coronary angiogram. But you need to compare this ECG with his baseline ECG, and what you notice is there is a S1 Q3 T3, and he turned out to have a large saddle pulmonary embolism, extensive bilateral pulmonary emboli, increased pulmonary pressure, and right heart strain. So He didn't need a coronary angiogram. He needed heparin initially, and then uh, 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 a direct oral anticoagulant. These are the chest X-ray findings I mentioned to you a minute ago. There's something called Hampton's hump, which is depicted here, a shadow at the periphery, thought to be due to a pulmonary infarction, and the Westermarck sign, which is a sign of reduced pulmonary blood flow. This is pretty subtle. But you can see here normal vessels in this area that's not well perfused. So, you need to establish a diagnosis of PE for hemodynamically unstable patients. Do a chest CT angiogram if you have time. But if not, you may need to treat the patient with heparin presumptively. For stable patients, consider the clinical evaluation and the pretest probability. Do a D-dimer, and depending on that, move toward a CT pulmonary angiogram. The VQ scan is more difficult to do, but if a CT angio is either contraindicated or not feasible or inconclusive, the VQ scan can be helpful. These are what's called Wells criteria, used mostly for ruling out PE. But the items on the score, symptoms of DVT, whether another diagnosis is less likely than pulmonary embolism, tachycardia, immobilization, previous DVT, PE, malignancy, and if the score is greater than 4, PE is likely. If it's less than 4, it's unlikely. Okay, so starting and maintaining oral anticoagulation in DVT-PE, if there's low bleeding risk, so you have to assess the bleeding risk. For DVT, if there's low bleeding risk, either DOAC or enoxaparin. If there's high bleeding risk, place an IVC filter. For pulmonary emboli in hemodynamically unstable patients, they may need to be treated presumptively with, heparin. But if the patients are hemodynamically stable and there's a low bleeding risk, either enoxaparin or beginning a DOAC, and then transition, if the patient's on enoxaparin, then transition to the DOAC. For maintenance therapy, the DOACs are preferred over warfarin. What about anticoagulation dosing? For warfarin, I think we all know this. Start with something like 2.5 to 5 milligrams a day and adjust according to the INR. For the DOACs, the dose of dabigatran is 150 milligrams twice a day. The dose of apixaban for AFib is 5 milligrams twice a day. For VTE-PE, it's 10 milligrams BID for a week, then 5 milligrams BID. After 6 months, you can consider cutting the dose down to 2.5 milligrams, which has been found to be effective at that time. For rivaroxaban, the dose for AFib is 20 milligrams. Incidentally, remind people to take it with food. For VTE-PE, 15 milligrams twice a day for 21 days, then 20 milligrams daily. For edoxaban, 30 to 60 milligrams a day. And if you need to or want to switch warfarin to a DOAC, you can do that when the INR has fallen below 2. I mean, it's a little more complicated than that, but this is a good general rule. If you're going from one DOAC to another, just start it the next day. The target INR for patients on warfarin is for between 2 and 3 for DVT-PE, AFib, rheumatic mitral valve disease, bioprosthetic mitral valve replacement, mechanical or the newer aortic valves. The INR target INR is a little higher, 2.5 to 3.5 for mechanical mitral valve replacement. The older generation aortic valve replacements, the cage ball and cage disc valves. And this chart just shows why the recommended INR is between 2 and 3, because under 2, the risk of stroke goes up. Over 2, or over 3.5, really, the risk of bleeding goes up. For the prevention of venous thromboembolism, following hip replacement surgery or following knee replacement surgery, there's a lower dose in the case of hips for a month, in the case of knees for about 12 days. For rivaroxaban, it depends, and the bigatran depends on the creatinine clearance. Okay, and which brings us to this. So since the bigatran, edoxaban, and rivaroxaban are metabolized more in the kidney than elsewhere, the dose reduction is required. With dabigatran, it's required for a creatinine clearance less than 30. For edoxaban, it's less than 50. For rivaroxaban, it's less than 50. With apixaban has less renal metabolism, and therefore the dose is 2.5 milligrams twice a day, regardless of your creatinine clearance, unless 2 out of these 3 are present: age over 80, weight under 132 pounds, or a creatinine of 1.5. So an 82-year-old with a creatinine of 2, you'd reduce the dose to 2.5 milligrams twice a day. But somebody over the age of 80, like my lady in the example that I gave you, her creatinine was about 1, as I remember it, but it was normal. And so she got full dose, 5 milligrams BID. Okay, now a common question that I get is, what about interrupting oral anticoagulants for surgery? Well, first, consider the procedural bleeding risk. So there are high bleeding risk procedures, okay, and low bleeding risk procedures. And the common ones that we encounter are, dental procedures, cataract surgery, GI endoscopy, upper endoscopy and colonoscopy. They're low bleeding risk procedures. And so this is the proposed schedule of the timing of interruption of oral anticoagulants for surgery. If there's minimal risk, so we're talking about minimal risk, say cataract surgery or colonoscopy, you can actually continue the anticoagulation, or you can hold the morning dose on the day of surgery. For low bleeding risk procedures, eliminate, stop oral anticoagulation 1 day before. For high bleeding risk procedures, stop it 2 days before. If you stop the direct oral anticoagulant 2 days before, the patient at the time of surgery is not anticoagulated. Which is different from warfarin, which you have to omit for at least 5 days. So that the last dose of warfarin would be on the 6th day prior to surgery. And then in any case, resume when bleeding is controlled, when the surgeon believes that it's safe. So here's a 68-year-old woman with non-valvular AFib, hypertension, and heart failure with preserved ejection fraction, who's on apixaban 5 milligrams twice a day and requires a dental extraction. Her JADS-VAS score is 4. So what's her thromboembolic risk? High, intermediate, or low? The short answer to that question is high. What's her bleeding risk? Well, we didn't say, but she didn't have any significant bleeding episodes, so we would say it's low. Should you interrupt anticoagulation? Well, you don't really have to, but you can just omit the morning dose. How many days? Bridging? No. Okay, so, well, I've already answered that. So let's consider bridging. When do you need to bridge? In the first place, avoid bridging in individuals with a low thromboembolic risk, which includes patients on direct oral anticoagulants or on routine oral anticoagulation for AFib. Or a secondary prophylaxis more than 3 months after peripheral venous thromboembolism. Bridging is indicated for mechanical heart valves, an embolic stroke within the previous 3 months, VTE within the previous 3 months, or if the patient had a previous thromboembolism during interruption of chronic oral anticoagulation. Which brings us to consideration of cancer patients. There are a number of different issues to be considered in cancer patients. What is the therapeutic goal? I mean, treat the thromboembolism. What is the oncologic therapy? Is the patient on hospice? Is there planned chemotherapy coming? What is the prognosis? Are there other causes of hypercoagulability, such as is the patient bedridden, or was there a pathologic fracture, or have there been invasive procedures? Some relative contraindications to anticoagulation in cancer patients might be CNS involvement, or bleeding diathesis other than, such as thrombocytopenia, or the presence of other risk factors for bleeding, such as hepatic metastases, or poor nutrition. The DOACs are preferred. Enoxaparin is sort of the second choice, where enoxaparin followed by warfarin is considered to be second-line therapy. What about the duration of therapy? And we're talking about low bleeding risk patients. And atrial fibrillation is really lifelong. Even if a patient seems like they're in sinus rhythm, it's still lifelong. An exception might be AFib due to thyrotoxicosis, at least 3 months after successful treatment with thyroid ablation through various mechanisms who have had a negative long-term ambulatory monitor, so they're not having AFib anymore. Although some experts rely on the CHA2DS2-VASc score. So, depending on the CHA2DS2-VASc score, you might want, even in this case, to continue anticoagulation. For DVT-PE, if it's provoked, the duration of therapy is 3 to 6 months. If it's unprovoked, probably lifetime. With cancer patients, it's until the patient is in remission or has a major bleed, or unless the DVT-PE was provoked, such as following surgery. And so, how do you manage the bleeding due to oral anticoagulation? Now, we're talking about bleeding requiring hospitalization. Stop the anticoagulation, right? Assess for and manage comorbidities, give supportive care, volume resuscitation, control bleeding, transfuse, consider a reversal agent. Although if there's non-major bleeding in a patient on direct oral anticoagulant, do not administer a reversal agent, and consider the need for anticoagulation. Reconsider the need for anticoagulation with shared decision-making. These are the reversal strategies for warfarin. It's a vitamin K, preferably IV in the case of active bleeding, because the oral preparation takes 24 to 48 hours to have a significant effect. And so the conclusion is that the anticoagulants provide us with the opportunity to prevent thromboembolism and its complications. Evaluate your patient's overall risk of thromboembolism and risk of bleeding, and decide on anticoagulation. Remember the therapeutic doses of the anticoagulants, and do not undertreat. That's a common problem in atrial fibrillation, is undertreatment. So generally speaking, for patients with atrial fibrillation, use the therapeutic doses. In which case, I thank you very much for your attention, and I'll be glad to invite any questions. If you want, you can put questions in the chat. Yes, you can have the slides.
Dr. Schulman, I'm just going to put a couple of reminders in the chat while we wait for some questions, okay?
Okay, sure. Go right ahead. I'm here. Not going anywhere.
Do you see that one, Dr. Schulman? What are the indications for using
Indications
Plavix?
for using Plavix. And the answer is, Plavix is clopidogrel. And the answer is not for atrial fibrillation. And not for DVT. So Plavix is useful for maintaining patency of coronary stents. It can be a replacement for aspirin in the prophylaxis of coronary artery disease, but not for either AFib or DVT. What I've seen is that practitioners will think that in a patient with atrial fibrillation, the risk of oral anticoagulants is too great, and so they don't want to prescribe that. Instead, they prescribe aspirin. It doesn't work, might as well forget it. Um, do not use aspirin, do not use clopidogrel, and think, not twice, think 3 or 4 times about the relative risk of thromboembolism and bleeding, and use full dose oral the full dose direct oral anticoagulants. Okay, so we're talking about, okay, here's another question. A patient who has paroxysmal AFib and a CHADS VAS score of 1, whose only risk factor is age over 65. So it would be a man who never had hypertension or heart failure or diabetes or vascular disease of any kind. Should he be anticoagulated? I would say yes. In that case, I would opt for treatment in that case. But I would also say that if he has AFib and no obvious cause, you should start looking for a cause. The subject of another lecture is cardiac amyloidosis, an infiltrative disease that causes a cardiomyopathy. And one of the presenting symptoms might be paroxysmal AFib with no obvious cause. Cardiologists tell me it takes 24 hours of continuous AFib to form a clot. That's probably true. Probably true. Today's pacemakers and defibrillators are also implanted monitors, and so AFib has been identified as taking 6 minutes, an hour, and it has not been shown that such short episodes of AFib cause thromboembolism. Let me say that another way. Episodes of AFib that short probably don't cause clots. It takes 24 hours, 17 to 24 hours anyway, before you want to consider anticoagulating people.
Okay, if we don't have any other questions, we can wrap it up. Thank you so much, Dr. Schulman. Thank you, everybody, for attending.
Okay, thank you.
Have a great rest of your day.
Okay, you too. Bye-bye.